All right. Thank you all so much for being here this afternoon. So I'm Lauren Datillo. I am the Education Director at Psychology Specialists of Maine, and we're so glad to have you. So part of our mission here at PSM is to learn and grow and lead and inspire others to believe in themselves and live to their full potential. So in service of that, we wanted to open one of our monthly lunch and learn presentations to other psychologists and therapists in Maine to help create connections between folks and also to raise some money for Oasis free clinics. So before Dr. Weiss gets started with the presentation, we are going to hear a little bit from Julia Bergquist, who is the mental health coordinator at Oasis.
Thank you, Lauren, and good afternoon, everybody. I want to first say thank you so much for those who donated to Oasis free clinics. It's very much appreciated, and every single dollar truly counts. Oasis Free Clinic is located here in Brunswick, Maine, and it is a free clinic available to individuals in the Brunswick, Harpswell Islands, Freeport, Durham, and Saginaw County area. We serve individuals 18 to 64 who are within that insurance gap, so are not qualifying for Maine Care or Medicaid, and who are not able to access or afford private health insurance. So we provide free services that include primary care, dental care, optometry, and mental health services. Mental health services look like accessing a network of volunteers. Lauren is one of them. We're very grateful for her time. And we also host LCPC practicum students at the clinic who I supervise and who see a limited amount of patients in our setting as well. Your donations help continue those services. We operate all on grants and individual donations. And should you be interested in being part of the volunteering experience at Oasis Free Clinics, I am here. Again, my name is Julia Bergquist, and thank you guys so much for this time together and for the sponsorship from Psychology Specialists of Maine. Thank you, guys.
Thank you. I just want to say Julia she's made it so easy to work for Oasis. She takes care of every administrative and scheduling and sort of logistical question. And so kind of the administrative burden is extremely, extremely low. And it's basically just an opportunity to provide therapy for folks who otherwise probably wouldn't be able to access it. So it's been really wonderful partnering with them. So let me, go ahead and introduce our speaker for today. So we'll be hearing from Dave Weiss. So Dr. Weiss is a staff psychologist at Psychology Specialists of Maine. He received his Ph.D. in clinical psychology from The Ohio State University and completed a predoctoral internship at Yale University and a postdoctoral research fellowship at the Maine Health Institute of Research. He has extensive research and clinical training in health psychology and first episode psychosis, and he recently published on patterns of substance use, including cannabis use, within youth with psychotic spectrum disorders in Frontiers of Psychiatry. So with that, we will get started.
Great. So everyone can hear me okay? Everyone can see the slides. I see thumbs up. Great. So the title of this talk is Cannabis Use, Clinical Considerations and Therapeutic Approaches. So certainly I'll be digging into cannabis use disorder, a very specific application of where cannabis use can go wrong. But I'm also of mind to devote some of this talk to how we'll see cannabis use co-occur with other types of syndromes that we see in clinical practice. So I don't have any conflicts of interest to disclose. I know Julia just talked about Oasis. A PDF version of these slides are available. You should be able to click that donate button if you haven't done so already. Okay, so here are my objectives for this presentation. I recognize time is limited, so I've attempted to really format this talk to focus more on translational or applied skills that I think are clinically useful. I know Lauren provided an introduction, but I'll just mention that I came to this work rather indirectly. Part of my training focused on psychotic disorders, particularly in adolescents or young adults experiencing a first episode. Cannabis use has particularly important clinical implications in that population. That being said, I found treatment resources specific for cannabis use to be particularly lacking. So my intention today is to review, my own knowledge on this topic. And then I've also provided resources on my slides in case someone is more interested in an in-depth look at some of these topics. So I'll start by reviewing general use trends. So this isn't cannabis use disorder, but just general problematic or non-problematic use of cannabis. So in the United States, and this holds relatively true elsewhere throughout the world, cannabis is the third most commonly used controlled substance after alcohol and tobacco. Prevalence rates of cannabis are about 10% or 1 in 10, although certainly there are national data sets that suggest that prevalence may be as high as 15%. Around 4.2% of adults describe cannabis use as occurring daily or near daily. And I'm highlighting that because that will be an important risk factor of cannabis use disorder, or what I would term more problematic use. On that 4% number, that would also include recreational and medical uses. So all of this is kind of lumped together when we discuss prevalence use. In terms of age of onset, or age of initiation rather, the median is around 18 to 19 years old, but the mean is around 16. And this is important because this is another risk factor that's indicative of cannabis use disorder or problematic use, that being that younger ages of initiation are associated with more risky use. That lower mean also suggests that there are more extreme scores on the younger side of that distribution. So again, something important to know and ask about as you encounter this issue in clients. So as I transition to talk about more clinical definitions of cannabis use disorder, this is a slide to remind everyone on DSM criteria and how that's changed over different iterations of the DSM. So this is going from 4 to 5. And these changes are consistent across substance use disorder classes. In my view, these changes have really simplified disorder diagnosis. I think it's probably more likely that people meet criteria. But I'm showing this because I'll be describing how prevalence or use rates have been fairly consistent over time, which is really puzzling considering other trends that we're going to talk about. So as I continue this talk, I'd like for each of you to ponder why cannabis use disorder isn't more prevalent, why we're not really seeing this as much as maybe we may, right? Okay, and so these cannabis use disorder trends, these come from nationally representative sample data sets. As I mentioned, prevalence disorder of the disorder that has been consistent over the past 20 years. Over the same amount of time, you see a decline in perceived treatment need. Now, that number is already fairly low, but it's continuing to drop as, people are not perceiving that this is an issue worth clinical attention. And then it would follow that if there's a lower perceived need of treatment, there is also a lower utilization of actual treatment. Again, that number is fairly low in the early 2000s, around 9%. It's dropping even further, 3% within the last couple of years. That's pretty consistent across ages, though there's certainly interesting distinctions based on age group. So young adults ages 18 to 25, they utilize treatment far less than school age adolescents or adults 26 and older. So, I think probably there's some perceived needs that are different between those age groups. I also think school, that's a controlled environment. There are probably more resources available to tackle a cannabis use issue, and that may vanish as people age out of school. So all of these trends in terms of use trends and disorder trends are interesting to consider in the backdrop of legalization changes. So that graphic is kind of cycling through how, states have really reduced that graphic, it'll just keep cycling. So try not to get distracted as you see the changes from red, meaning cannabis is prohibited, to relaxing of laws to allow both medical and recreational. I think these changes are really interesting to consider, especially in the context of DSM diagnostic criteria. So if you have decreasing legal or occupational consequences of use, that's going to likely make it less harder. There's also been more specific work about the perceived harmfulness of cannabis. So that has declined over the last 20 years. Again, if people are perceiving that this is less problematic, they're not going to bring it up in a clinical setting. Thereby, it's going to be less likely to make that diagnosis. All of these kind of cultural, legal, social changes are occurring in the backdrop of potency increases in cannabis. So the potency of, medical and recreational cannabis has really kind of exploded over the last 20 years. You're seeing increases by a factor of 3 or 4 in potency, yet, you have stable rates of use disorder. We're not really encountering this that frequently clinically, at least, as pervasive as I think this issue might be. I also think there's some utility to thinking about cannabis from a comparative lens compared to other substance classes. So one difference is cannabis has, wide-ranging and often legitimate therapeutic uses, especially when we talk about medical uses. So that text below that header, that comes from 1999 legislative text from Maine. Those are conditions that they approved of back then. They still hold true. And I would venture to say all of those conditions that are listed, yes, that they have good evidence that marijuana or cannabis rather is effective for either symptoms or particular pathogenesis of the medical condition itself. There are states, and I think Maine might be one of them now, but there are states that approve cannabis for mental health conditions, such as anxiety conditions or PTSD. And then you also do see some expansion to behavioral health conditions, particularly I'm thinking of opioid use disorder. So I'll just mention that the evidence of that is less conclusive compared to medical conditions. And I'm pretty leery about it just because I do think there are folks for whom cannabis is contraindicated, particularly in PTSD or with opioid use disorder. But I just want to acknowledge that you do see that, and I wanted to mention that. There are substance use classes that do have medical uses, opioids being used for pain. I think about the emerging psychedelic research for mental health conditions, but I think at the very least, we can say that cannabis has a more wide-ranging therapeutic uses compared to those other drug classes. Just a note on psychedelics, there are some researchers that do categorize cannabis as part of psychedelics, but the majority do not. They are considered separate by the majority of the field, I'll say. In terms of other distinctions, I do think when we think about pharmacological dependence or withdrawal. There are less medical concerns about cannabis dependence and withdrawal, just from a pharmacological perspective. I do have up here cannabinoid hyperemesis syndrome. That is very rare, but can occur in chronic pervasive use of cannabis. This is categorized by kind of cyclic vomiting that does resolve upon cessation. Even though it's rare, I mention it because I think it is going to be a rare case for someone to present clinically for specific help on cannabis, but that would be the exception. If someone is having that syndrome, I think they're likely to be motivated to engage in cessation work. And then finally, I think the other big distinction that comes up for me is the lack of treatment options. So specific to cannabis. So even though it's the third most commonly used control substance, we certainly lack both psychosocial interventions specific for cannabis and also pharmacological options. You know, we have nicotine replacement therapy for tobacco, we have Suboxone for opioid treatment, but we certainly don't have anything to substitute or replace for cannabis. You know, sometimes people will prescribe either antidepressants or mood stabilizers for withdrawal symptoms, since those are particularly non-specific or more psychological in nature. But again, you really don't have a specific pharmacological option for cannabis. Okay. And so certainly cannabis, I'm talking about odds ratios here. So this is, you know, how closely would you encounter cannabis with something else? And so these odd ratios imply that for someone that's diagnosed with a cannabis use disorder in the past year, someone would be 9 to 14 times more likely to develop another substance use disorder during the course of the year. And you can see the specific odds ratios for individual substance use disorders on the left. On the right, those are associations for psychiatric concerns. So psychotic disorders lead the way here, but certainly, you know, this is going to co-occur across most types of mental health conditions. So this isn't to say that cannabis use causes these conditions, right? You know, my intention here is to kind of ring the alarm for clinicians, you know, who may not be asking about cannabis or maybe thinking about how cannabis exacerbates or perpetuates, you know, mental health concerns. You know, I use this to kind of ring the alarm if it's not on your radar. So from that slide, you might ask yourself, you know, what comes first? You know, does cannabis use precede mental health disorders or vice versa? I think, you know, there's a lot of mental health professionals here. We know the answer is not simple, right? There's going to be a lot of factors at play here. Certainly the strongest evidence for causality comes in cannabis, or for psychotic disorders rather, where there are independent studies that suggest both the frequency of cannabis use and the potency of cannabis use, you know, does result in an increased likelihood of later developing a psychotic disorder. You know, that being said, I've worked with individuals with psychosis that never have used cannabis, or I've worked with people that develop psychosis and then, you know, use cannabis to cope with the symptoms of psychosis. So again, I say that I offer this because I think at the very least, you can use this research to provide warning or to inform your younger adolescent or young adult clients. You know, listen, you may not look at your cannabis use as a problem, but, you know, it's not as though the risk is zero. You know, there is increased risk of developing a psychotic disorder. And that would especially be true if there's any kind of family history for either psychosis or bipolar. Now, that graphic on the right, I've selfishly included, data from my research that I've done. So this was an experience sampling study in adolescents, young adults with psychosis or who were at risk of psychosis. So one striking thing in this study, and certainly it's a small sample, but the rates of use were rather low, I thought. These are adolescents, young adults. This is the kind of age in the lifespan where people experiment with substances, but, very low rates, at least comparatively to what other samples, other studies have observed in this population. But what was really striking was the frequency of use in this sample. And so experience sampling, for those not familiar, you prompt people, typically through a smartphone, multiple times a day to answer questions about psychological symptoms or substance use in this case. And so this was a sample where they were queried 6 times a day for a 3-week period. So that's a lot. It's a lot of prompts. And so what this data says, for people that are tobacco users, 75% of the prompts they're smoking, they're using tobacco. For cannabis users, 40% of the prompts, they're indicating that they're using cannabis. So, if you're using cannabis half of the day, that's a lot of cannabis use there. And so again, thinking about this isn't just a yes or no question, but it's about the frequency, it's about the potency of use. Okay, so that's kind of background information. I may have ran through that quick, but this may be a good opportunity. Lauren, are there any questions in the chat, anything that people want to ask about before I move on to assessment?
Nothing in the chat yet. So if folks have questions, you can feel free to unmute and ask now, or put them in the chat, whatever feels most comfortable for you. I do have a question. I heard you sort of correct yourself earlier about essentially the difference between marijuana and cannabis. And I thought, I don't actually know what the distinction is between those two. So yeah, are they just...
That's the question, because I didn't make the slide, but I did think about language. Language is really important. I am going to touch on motivational interviewing, which I think is really important in terms of being careful about language. Cannabis is the kind of scientific official name. There are kind of social and cultural meanings that get imbued on other terms, marijuana being one of them. So again, if someone calls it marijuana, I will go with their language. If someone calls it weed, I will, follow and mirror their language. Yeah, language is important, but when thinking about a scientific talk, I do try to stick with just cannabis, but that's kind of flexible, fungible. Okay, so I'm going to transition and talk about assessment, and I did try to highlight things in that first portion of the talk that may be helpful in terms of thinking about whether use is problematic or non-problematic. So I'll offer kind of 2 things here. I'll offer the basics, which I hope everyone will leave this talk and be comfortable in doing. And then I'll really talk about my own kind of thought process of how I approach cases and how I incorporate assessment in an ongoing basis. So to start, I began the talk thinking about just the lack of resources specific to cannabis use and cannabis use disorder. So I borrow from the literature. Certainly, I have a lot of experience with tobacco cessation, and I think about what we get right about tobacco cessation and how we might use that for cannabis. And so I think about the 5 A's. The 5 A's of smoking cessation. If you're familiar with this, this is really about encouraging clinicians in a primary care, or I even think in mental health, an outpatient clinic capacity, how to engage people in a brief time-limited way to encourage cessation, or at least thinking about cessation. And so as I go through the remainder of the slides, I'd like you to think about how you would incorporate this kind of technique in your own practice. So the questions I'd like for you to ask yourselves now is, how would you advise someone to quit cannabis? You know, how comfortable would you be assessing their readiness to quit cannabis? How would you assist them in their quit attempt? And then finally, I think about how frequently would you be willing to follow up with them on their use or on their use changes? Okay, so you may not have all the answers to those questions now, but hopefully you will as I go through the rest of the talk. Okay, so the basics here. In terms of asking, I can't stress this enough, this is not just a yes or no question, but you really do want to gather other types of information. So, you know, within the yes/no question, I'd also capture kind of reasons for use. And with this, I think about, you know, whether a reason is medical or recreational. Excuse me. I think about this because, you know, recreational use is more reflective of an increased likelihood for, you know, problematic use or cannabis use disorder. So next, you'd want to ascertain method of use, quantity of use, potency of use, and frequency of use. So method refers to how the drug is consumed or ingested. Most commonly, you're going to encounter smoking or inhalation. Frequency refers to how many times per week or per day. So, you know, clients will usually be clear about those two questions. You know, the other two become more murky, but that's okay, right? This in itself, you know, I really do believe of assessment as intervention, and I think that's really clear with this. So quantity, you know, per use is really difficult to establish. It may be helpful to know how cannabis is sold. It's sold by weight typically, especially if you're talking about flower or kind of smokable cannabis. You know, it's weighed in grams or in larger quantities, ounces or proportion of ounces. So typically I'll ask people how much they buy and how long that will last them. And that can get you an approximate of the quantity that is being used. Now, potency is very tricky. More often than not, clients will not know. Okay, so at the very least, you just want to try to provide information that will help them become a more informed consumer. So the element that you want to assess is the amount of THC in whatever they're purchasing. So THC refers to the psychoactive component of cannabis. It's the thing that's responsible for the experiential high that someone will get from consuming cannabis. And certainly this is an element where less is better. So you want less potency in either equal or greater amounts of CBD, which is a non-psychoactive component, but that is purported to have some of the benefits that people derive from cannabis, mainly kind of anxiolytic properties, muscle relaxing properties, that sort of thing. You know, this would be kind of lowest on the priority, but, you know, if you can establish age of initiation, again, that might get you, you know, whether someone starts at a pretty young age, that's going to be more reflective of problematic use. 15 is a nice dividing line there. So 15 and younger, you know, that is the factor that you're kind of looking for. That graphic on the right refers to an assessment tool that you might use. It's very easily scored. It's also suggestive of, it'll give you scores, you know, that may be reflective of disordered use. I think that was included with the reminder for the talk, and that's free use. So feel free. So less basic. Like I said, I'm trained as a health psychologist, so I think of health psychology theory all the time. And not that I assess this explicitly with people, but I kind of keep it in my mind in the background in terms of looking for opportunities to perhaps encourage or bring in cannabis cessation as part of treatment. And so for those not familiar with the model, this is basically reviewing factors that influence health behaviors. So one's perceived susceptibility or how likely something is given the behavior. Additionally, severity refers to how, the level of consequences given the behavior. What are the person's perceived benefits and barriers in doing the behavior? Is there a cue to action? Hint, we are the cue to action sometimes, right? We can be an external cue in order to motivate someone to quit. Cues can also be internal. And then self-efficacy, or the confidence to perform the behavior. So, like I said, I don't necessarily assess these explicitly, but I think of these more as mechanisms that are changeable, and they're changeable in a way that allows individuals to approach their own behavior, in this case, cannabis use behavior, in a different way. So this may be an example, right? And again, I'm not learning this in session 1. I'm learning this over the course of our work. So it's an example of how these health belief model factors might come up in relation to cannabis use. So like in this example, imagine that the person's primary goal, the reason they're coming to see you, is to reduce depressive symptoms and interpersonal conflict with partner. And they were very clear up front that they didn't view their cannabis use as cause for concern. So that's all well and good, but over the course in time, that perceived barrier, that cannabis, the partner doesn't like cannabis use, then that becomes a way to incorporate this if the goal is, reducing depressive symptoms and reducing interpersonal conflict. So I might really emphasize those perceived barriers. At the same time, I might try to figure out a way to replace that perceived benefit. Cannabis use helps me relax, replace it with something else. And then addressing the self-efficacy. Well, you don't know how you would stop or quit. Well, let's talk about what that might look like. So again, it's not like I'm informing people of these factors. It's just a way for me to conceptualize it and bring in something that the client may, say no, but I'll figure out a way to work it in. Okay. So intervention, so I'll stop for questions if anyone, I think there's one in the chat, but I want to say that the division here is arbitrary. I've talked about how I think of assessment as its own form of intervention, but again, recognizing that, I do think that there will be things from the intervention portion that can be used for assessment.
Yeah, we had a comment in the chat that sort of talks about essentially a potential history of the term marijuana, and how essentially it seems like perhaps it was a way to perpetuate some negative stereotypes about marginalized groups, which I could see that. You might sort of get into this. This might be jumping ahead a little bit, but I'm thinking about sort of the process of helping people decide whether their goal is reduction or cessation.
Yeah. I will get into that. I think that's going to vary. It's going to vary based on the clinicians' kind of thoughts or biases about this. Sometimes I worry that I may be overly permissive of use. I maybe not though, because I do think my work in psychosis really has informed, the kind of potential risks or consequences of what may be benign use of cannabis, right? But that's going to be tricky. I'm going to cover both. So I'm going to cover my basis with that.
Yeah.
So in terms of this section, I will get into the different types of interventions that are available. Warning, there's nothing specific to cannabis, so it really does borrow from principle-based treatments that have been applied to other substance use concerns. And then, I think I'll have enough time to get into some of the vignettes. Okay. So, like I said during the intervention portion, I think the most common clinical issue that you're going to encounter is a client that doesn't perceive the need to incorporate this into treatment. They're coming for you for depression or anxiety. Cannabis is just something that occurs in the backdrop. So, they don't consider there used to be problematic, and hey, I am willing to accept that as a possibility. Maybe this really is non-problematic use. But at the very least, I think a harm reduction strategy, right? And so what you were talking about, Lauren, thinking about whether we're talking about complete cessation here or whether we are more talking about reductions. Well, I think at the very least, we can talk about reductions, especially for those folks that don't perceive a problem. And again, I think that it's about helping people becoming more informed consumers of cannabis. I have had a couple, but I really have very few clients that are able to answer all of those questions that I had went over before. And usually it is quantity and potency that people cannot answer. Now, I'll tell you, unfortunately, the environment right now is not helpful to us. There are no labeling standards. It differs by state. However, the states are regulating cannabis, those kind of labeling, licensing standards, it's a hodgepodge. So I forgot the link with this one, but that table comes from a Canadian website, Ottawa Public Health, because we're not doing a whole lot in this country in terms of informing people how to be informed consumers. So, this table is a nice example of how to determine potency. So you can see for that dried or fresh cannabis, that top line, the example 0.7, that would be low potency. That would be, preferred from that second line, total THC 14%. That's high level of potency. Now, the difficulty that I've encountered with clients kind of coaching them through this is that they purchase cannabis that doesn't have these labels, right? It doesn't have these descriptors, which is a problem. And so, but even then, maybe you go to a shop, maybe you take this as a sign of you want to purchase cannabis from a reputable site that is upholding the state standards. Maine does have the requirement that these potency labels are affixed to products, but it's not being enforced. I have clients time and again say, I don't know the potency, it's not listed anywhere. So that would be kind of the bare minimum strategy for all clients, to try to take a harm reduction approach. And again, you want to encourage lower potency with an equal or higher amount of CBD, which is the non-psychoactive component. And then finally on this slide, those two images in the bottom right there, those are Maine specific. So it contains THC is required for all products to have that label on, contains THC if they have THC. But again, many of them do not. And then that not safe for kids, that's optional, which maddens me, right? Because then if it's optional, if you have one with the label and one without, does the without imply that that is in fact safe for kids, since some do have it? So again, it really is a hodgepodge of laws. They're not enforced. There's no guidance on this. And so I think we are in fact the frontline guiders on this. So I'm going to go through this really quickly, just so we can have time to go through the minutes. But I also think about, as I work with clients, helping them through these stages of change. So again, I think if you have someone that's coming in and their primary concern is treating cannabis, I think that's going to be a rare case, but great. You have someone that's already in the kind of at least contemplation, but more likely in preparation in an action phase, and they're looking for you to encourage, that kind of plan. More often than not, I think most of our clients are going to fall in this pre-contemplation phase. They are not considering that their cannabis use is a problem, or even that it's impacting the problems that they're coming in with. Over time, you might take the opportunities to try to shift their thinking throughout the stages of this model so that you can get them to, the action and maintenance phases. The arrow just go back, the arrow refers to relapse, that it's not like you set it and forget it, right? If people do achieve cessation, certainly something may happen, they may kind of relapse. You can kind of go through this cycle again. Ideally, you can move through it quicker than you did the first time. So just kind of acknowledging that this isn't static, that this is always kind of in flux or dynamic. Okay. So I know that my time is limited here, so I've tried to highlight the three, I think, more helpful kind of treatment approaches. These are all principle based. I've been trained on all of these, and I've tried to highlight, I think, what I find to be the most useful factor for me in terms of treating this. So with motivational interviewing, I've mentioned about how the language is important, but I really think about motivational interviewing in terms of trying to bring cannabis into the conversation when the client doesn't perceive it as an issue. And I think I do that by trying to frame cannabis use behavior as impacting or being discrepant from the goals that they've identified. And I think, that it can really only happen with time when I've gained trust and rapport. And, I think there's a greater willingness to be receptive to how cannabis use may be impacting goals. In terms of contingency management therapy, now I've only ever used this on a more controlled environment, like residential or even an inpatient setting. But I think there is a lot of utility to this, especially if you're promoting cessation in adolescents or young adults. With school or with family involvement, there might be more opportunities for a controlled environment where you promote reinforcers over punishers. So just thinking about kind of learning and classical conditioning, I think CM has a lot of utility there. And then finally, I'm a CBT person. I know all of you may not be, but I am actually not familiar with that text. It's brand new. But I think in terms of what CBT offers, I really like just kind of recognizing the shame and guilt spirals that people can fall down to, especially when it comes to resisting, encouraging cessation, and then relapsing. Then the substance itself becomes a way to minimize those shame and guilt feelings, and you're kind of back, maybe even worse where you started. So I think that's the real benefit of CBT for addiction treatment there. Okay, so we have some time. I'd like to dig into some of these vignettes. So, these are simplified. They're meant to be overgeneral. I just want to go through these and talk about decision points. So upon a first visit, I meet with JD. She is a 30-year-old single white female who presents with chronic anxiety and depression. She's worked as a pharmacy tech for the past year, but prior to, she had a 6-month leave of absence from work that coincided with the end of a 4-year romantic relationship. It's a depressive episode. She doesn't use tobacco. she drinks alcohol socially. So I get there's a lot that happens in that first session. What sticks out here, I haven't assessed for cannabis. So certainly, I'd want to go through and dig into if there is cannabis use. I do that on the second visit. And what do you know? So this is someone who smokes a bowl. This is where language becomes important. There are 1,000 ways to describe the kind of paraphernalia, also puffs, hits, intakes, inhalations. So the language can be quite dizzying. But again, I tried to mirror what the person is talking about. So this person admits to using one bowl, 3 to 4 hits nearly every day. She began in junior year of college, so rather late on age of initiation, and she believes that cannabis use helps her sleep, it helps her relax. Okay, so certainly with this, I'd want to take that informed consumer approach, right? And just ask her about potency. She is not familiar. And so I may advise her to go to a lower potency and see if she can still derive the same benefits. Even if it's not a part of her treatment plan, I am thinking about the ways that it may result in depressive symptoms. So if someone is using on a daily or nightly basis, is that removing them from reinforcing situations? So she may be isolating when she uses, right? And so just thinking about, they may not make the connection between use and their depressive or anxiety symptoms. That's kind of the job of the clinician, to observe and try to point this out in a kind of non-judgmental way, and that'll help bring this to focus for them. Okay. So next is a little different. So GL is a 47-year-old married white female who presents with anxiety concerns. Here we're talking about uncontrolled worry, irritability, muscle tension. She does describe exacerbation of these symptoms in the morning that can often include nausea. It makes it difficult for them to eat. Doesn't use tobacco, has a glass of wine with dinner on most days, uses cannabis over the weekend. And when we define that use, we learn that the quantity is maybe not so high. There was a period of time with more regular use in her 20s. And for the most part, we can define this as recreational. So again, this is a case where I maybe won't do a whole lot other than to engage in that thorough assessment in a way that allows the person to become a more informed consumer. And so maybe, they would consider a point that they don't go for a kind of product that has high levels of THC. Maybe they do try CBD. Again, in a way, is it ideal? No, but if we're talking harm reduction, certainly better. Because this is confined to weekend, I'm not sure what kind of impact it has, at least, in initial glances on the anxiety symptoms that she's describing. But again, it's something that I just want to keep watch for. And maybe while I'm willing to let it go now, maybe with more information, it does become more reflective of how impactful that may be. With this case, because it is kind of confined to a period of time, there may be something like sleep disturbance, right? Something where the weekends are much different from the regular work week, where, there may be some differences in symptoms based on the differences in behavior. So again, that might be the one area that I'd watch out for. But yeah, this may be one where I'm more hands up in the air, wait and see approach. And then finally, this is more specific because I do think there are potentially good lessons, especially for those that do have adolescent or young adult clients. So here we have DJ, 19-year-old, single, Hispanic male, who presents with his mother, who helped facilitate the appointment. We have an adult client, but certainly there's that kind of middle ground where not a full-fledged adult, not an adolescent either. DJ has recently had a bipolar 1 disorder diagnosis, had a leave of absence following an onset of a manic episode, established med management with a prescribing physician. He's in agreement. He's agreeing to try therapy. He's really motivated to kind of get back on track. Wants to go back to school, describes binge drinking with friends when on campus, uses cannabis a couple times a week. And I've seen this time and again, when you interview people with family, the disagreements come to bear. So this is a kind of intake situation that devolves into an argument, right? Mom is well aware of risks that son is not. And so even with this situation, I think about how we're reframing goals. So what's highlighted here is how DJ and his mom disagree, but I know that there are things that they agree on. They're both here in the therapy appointment. They both want him to get on track. And so I remind people that we can agree on the goal, but we may differ about the method. And that can be fine, right? DJ is not ready to consider how, cannabis may harm or put him at risk, right? But again, he may observe the ways that does happen for him as you do the work. And for him, it won't be about quitting marijuana. That's not the primary goal. But he may see that, oh, marijuana is not helping me get back on track, right? And in some instances, he may observe that it hurts him. But again, that has to occur with time. You're not going to be able to encourage that or force that on him right off the bat. So I know that was really quick and simple, and I've only left 5 minutes. So thanks everyone for your attention. I know there's not a lot of time for questions. There's my email address. If you have questions or want more resources, please feel free to reach out. And then just as a final announcement, we are offering an ethical CE opportunity for 4 credits, and that's coming later in July. It's a half-day program.
January.
January, I'm sorry.
That's okay.
Okay.
All right, if folks have questions, you can just feel free to unmute.
I did that great, huh? Well, hopefully everyone is feeling more confident and that there is a takeaway from this, but yeah.
I've got a question. And this is Diana Prescott. Can you hear me?
Yes.
Okay, cool. I have a client I've seen for a long time who came to me. It sounds a little bit like Vignette One, came to me with significant depression, and I've worked with her over time, and she's sort of at a place where I think she's more interested in taking this on. I guess I feel a little bit, it's that old struggle that I think we all have, or not, shouldn't assume everybody does, but when we first started training, those of us who are older, you're not supposed to get into this area. And, of course, everybody's using substances, like, how do you not get into this area, So I just feel a little, as I'm thinking about, talking about her use, I can do sort of some of the basics, but I'm just not sure where to start, I guess. And I might need to sideline you to talk a little more specifically about that, but do you have any thoughts?
Yeah, so I would sometimes in terms of thinking about behavioral health goals, I think there is a kind of pivot point where people become interested when they were not. And sometimes I think that motivation can work against people. And what I mean by that is when people start engaging in behavioral health goals, they kind of overpromise themselves what they're looking for, right? And so so for her, I don't know if her goal is complete cessation, but if it is, that might be a bridge too far, so to speak, because there will be instances where she craves, where she uses, and that can be disappointing. So
Yeah, I think the guilt and shame associated with family knowing of the use, they don't know, is part of her motivation.
yeah, so even just thinking about reduction, because what happens if you kind of lower the goalpost a little bit, that kind of achievement in itself can be motivating. So if you can kind of clearly define what her current use is, and then think about just reduction from a stepping down perspective, that as she achieves success with those more slower step downs, that is a kind of motivating thing that can catalyze itself and keep going. But I'd be happy to talk with you offline about ideas. In terms of the concern, I think that makes sense when we think about other types of substance uses, because there are kind of medical concerns that are kind of out of our wheelhouse. Cannabis does not have those same kind of medical concerns. It's not as though cessation is going to result in a kind of medical emergency. So I get that kind of apprehension in other realms, but I do think cannabis is a little bit safer ground for us.
I had a question on my mind, Dave. I think I know the answer to it, but the distinction between indica and sativa, does that matter at all in treatment? Because I've had clients who say like, I switched from indica to sativa and I'm doing much better.
Yeah, I mean, there are differences. I mean, there are, and then there are not. I think some are kind of perceptual. Who knows if there's any kind of valid basis. Certainly from a pharmacological perspective, I always mix up the difference, but it's purported that I think the indica plants typically have higher THC potencies. There are kind of more fine grain differences between the two. I don't want to muddy people's understanding, or my understanding isn't that clear, as you can tell with that. I think it's if you can distill it down to THC and potency, the strain matters less than whether how potent it is. And that's how I look at it. Yeah,
that's what I figured. And it's also seemingly very arbitrary of
yes.
What makes up indica and what makes up sativa.
Yes. And, knowing the kind of labeling standards, I am not so sure shops are being honest. If, the sativa plan is really a sativa plan. Again, it's a little bit wild, wild west out there.
Mm. Thanks, Dave.
All right. Well, thank you all so much for being here. I know lots of folks probably have places to go at 1 o'clock. So we sent out an email with a brief anonymous evaluation so we can get feedback on this and future presentations. I will send a follow-up email later this week with a link to your continuing ed certificates. And then in a few weeks, once the video is edited and uploaded, we'll send a link. So in case you want to refer to something later or rewatch, you're able to. Some of you all, it seems like maybe the reminder went to your spam folder that I sent on Sunday. So if you don't see that, make sure to check for it because it has a link to the QDIT, that measure, and a copy of the slides. So if you need anything, please feel free to reach out to me or Dave. And thank you all so much for being here, and especially for your donations to Oasis.